Oh, okay. So George is a great example of a difficult airway. He's got this very short mandible. When we're looking at the distance between the thyroid cartilage and the chin, we'd love it to be 3 finger breaths. On George, it's only 2. And what that means is that that's where the tongue goes when we are displacing with the retractor, with the gauze. So if that area is really short, the tongue is going to go back into the posterior pharynx, and it's going to obstruct the epiglottis, the glottic opening, which is where air travels from either mouth or nose into the lungs. So that's what our challenge is, to maintain an airway, maintain visual field for Doctors Wilson, Hinchey, Benton, Kwasny, and ultimately keep this person breathing. So if you want a video from above, a laryngoscope just to help, and if you guys want to kind of look in, so you can see this guy's little tongue's kind of big. You can see the dark red is the soft palate. All right, you can see the uvula back there, and that, see, there you go. The uvula is the soft tissue from the soft palate that separates the posterior pharynx and the nasal cavity, because obviously our nose is open to allow for air. And then when I come in, so if you come from that angle, should be able to see down in. So way down in there, you can see kind of a U-shaped. So that would be the glottic opening. So when we're packing things, we want to make sure that we're not packing the tongue down over the glottis, because that's why then we end up with no end-tidal CO2. So I have a couple of devices, and I'll go back over. So we have nasal airways, and sadly not the right size for him. However, this is the only size that will actually pass through the plastic of my guy. What I want you to notice is they're beveled. In our nose, we have 3 turbinates, and they can get sheared off. It's why people get bleeding. So you'll find KY jelly in the rooms. There's also one standing on the anesthesia machine. Don't cover the airway, because that's the first thing that they're gonna breathe in, and that can hit the vocal cords and cause them to spasm. But you just want to put a little bit along the sides. A lot of times I will put it right on the nair itself. And then you want to turn think about this as a knife. So we don't want to shear that turbinate off. So I turn it with that away. So it actually is backwards from the way it's going to place. But as I'm sliding in, I want to slide through those turbinates. I know. And then as it gets beyond the turbinates, then I can turn it. And what it does is that stents open the soft tissue in the nose. There's a hole in it. And you'll see, if we've decided to go with a nasal airway, I will cut the end-tidal CO2 and the oxygen and slide them down to try and get both readings. Okay? To actually determine the right size, some of it I look at the meatus of the nose, but in actuality you're wanting to look at distance of nose to ear. Okay, so this is more the appropriate size. It's just not going to pass through on him. Okay?
And is it also, you can look at their pinky?
You can look at their pinky. But sometimes, so like, this is probably the right size for most of us, just to provide the conduit in width, but it's not long enough. So as you look, these are rated in French. So this is a 20 French. It's the smallest one we have, versus this is the 30. I think we also have a 32. I typically will grab a 26 or a 28. That seems to be about the right size, unless we have our very large men. And then we're gonna need, from the length standpoint, we're gonna need this. Another thing that can be used, I've contemplated it on more than one occasion, is the pediatric endotracheal tubes. So the 4.5, 5.5 uncuffed tubes can be used as nasal trumpets. They then have an adapter that you can hook up to oxygen, which would probably be a little bit better for us in some of our longer, more challenging COPD, sleep apnea patients. One of the reasons a lot of our patients have sleep apnea is they are obese and they have a lot of fat in this back tissue. Not being discriminative or unkind, it's just a fact that when we give them sedation, they lose the support mechanisms and those tissues collapse down so that they are obstructed, and you'll hear it. You'll see them retract, where you can see their stomach moving and then their chest walls collapsing. Why that is so important is we can cause what's called negative pressure pulmonary edema. So if they are like this for too long, they will create edema in their lung tissue and then become hypoxic. So paying attention to how we're holding their airway and making sure that they're not creating that negative breathing attempt is, again, one of the many balances that we are struggling to do. Sometimes all you have to do is jaw thrust, and I've talked with most of you about if you get behind the angle of the jaw and push forward, you can open up, lift up the soft tissue that's right here and help displace that so that the nasal pathway is open, even if the mouth is full of gauze and blocks. I put out endotracheal tubes. This guy can be intubated. So if you've not seen emergency airway stuff, this is actually the pediatric laryngoscope. It's what I use on him just simply for airway management, but it would be too small for adults. We have two different types of blades. These are called Miller blades. They are straight. And then Macintosh are our curved blades. These can be found on top of the emergency cart. There is a tray with a towel on it. We have the good old-fashioned laryngoscopes. On the anesthesia machine is our video scope, and that most likely is what we would grab. But we have.
What's the difference between the curve and the straight?
It has to do with the way it gets used. So the Miller, you want to look in. So the Miller slides down the center and actually goes into the between the vocal cords. And I can't see let's see what we can see. If you come at it from like where Casey is, let's see if we can. So can you see down there there's a little bit of a triangle hole. Okay, so that's how this one would come in. The Miller or the Macintosh is curved, and it literally lifts up so that it goes into the space between the vallecula and the tongue and lifts up the opening. So you can see how instead of being all the way into the epiglottis, it sits above it and lifts it up.
Okay.
And that, for most practitioners, is feel. If I'm placing a nasal endotracheal tube, I'm most likely going to use Miller or a Macintosh. If I have a difficult intubation, I may go with a Miller because I'm going to get to the airway.
Okay.
I'm going to get into the airway. Let's see. If you're asked to, if we're in an emergency situation and you're asked, finding a style, there should be stylets, putting a stylet in, because it gives the, and connecting a balloon or a cuffed syringe to the cuff balloon and making sure it's collapsed. That way then, as we're looking, we have something firm. The tubes, when they are not styleted, are very, very flimsy. And so this helps to give some direction to where we're going. Okay? Also on the side of the machine, in the machine, in cooler, is a very long stylet. It's called a bougie. It can be placed, yes, it's bougie like Applebee's. We hope we didn't have Applebee's. We can place the bougie and then slide the endotracheal tube over it. So it's an emergency. If we are struggling, it's another option of how to try to find an airway, particularly on these big rotund people. What questions do you guys have? Did that help a little bit?
Yes.
Seeing what those structures look like?
Mm-hmm.
Okay. The uvula is the one thing that when you're suctioning, be very careful because it can get real edematous. We've all done it. So people will complain. All right.